The really important message from the presentations at this meeting is that immunotherapy is now a cornerstone of oncology. You know, we always have had surgery and then radiation therapy and chemotherapy as the three-legged stool that oncologic therapeutics sat on. Now there's another leg, immunotherapy. And it's cellular immunotherapy, meaning using the cells of the immune system, either T cells or natural killer cells, to treat cancer. Recognizing that that's a pillar now of oncologic therapy going forward, particularly in lymphoid malignancies, and I think soon to be applicable in other fields, it becomes important for the practicing oncologist to preserve the immune system. Unfortunately, many of the chemotherapies that are used to treat lymphoid malignancies, lymphomas, and leukemias kill normal immune system cells, normal T cells, normal lymphocytes, as well as they kill the malignant, and maybe even better in some cases, kill the malignant cells. And then if a patient's been through a lot of these treatments and they come to us for cellular immunotherapy, we can't get the cells from the patients that we need to manipulate to make a therapeutic agent for them. Now, there are there's active investigations around that where people are developing off-the-shelf CAR T cells, meaning they don't have to be derived from the patient, his or herself, but can be from a sort of a universal donor, an engineered T cell. And so a lot of the sessions that I went to that were even outside the meeting with some of the companies and some of the scientists, this was an active area of discussion, and it's a big thrust in development. But I think we have in our hands right now, FDA approved, you know, for pediatric ALL, young adult ALL, and diffuse large B-cell lymphoma. We have already one CAR T cellular immunotherapy product approved, and so when you're managing those patients, keep in mind that these are derived from the patient's immune system cells, their own T cells, and that we need to preserve that. So if somebody fails primary therapy, okay, it's probably time to hook them up with a center that's involved doing this before you go on to the next therapy, so that if they need to harvest T cells or something like that, they can sort of partner with the practicing oncologist to work out the best strategies for next therapies to preserving the immune system and scheduling, you know, collection of T cells vis-a-vis, you know, bridging types of therapies that are going on. So I think that particularly with these lymphoid malignancies, the practicing oncologists need to be quite familiar with their regional centers that offer this form of therapy, and to bring patients early to the attention of those centers when primary therapies are not working.